everybody. Like the man just said, my name is Nick Bonds. I'm a consulting attorney with the Phia group. If you haven't heard of us, we're a kind of a subrogation, recovery, claims negotiation, all things compliance specialists based out of the Boston area. I myself grew up mostly in Houston, Texas, lived most of my life there, but I've bounced around a little bit to the Boston area where I started with the Phia group. Now I'm coming at you from Atlanta. So it's nice to be here with everybody today here in Oklahoma City. We're gonna kind of dive in here to everybody's favorite topic, rules. Bear with me here a little bit. I know the theme here today is kind of ending the monopoly. We're using a lot of the monopoly imagery. I think we've got a monopoly board on this podium right here. And one of the things that everybody always does, like me and my family growing up, whenever we would play Monopoly, the first thing you do when you start reading the Monopoly rulebook, what do? You change the rules. You start making your own rules. You make your house rules. What are some classic ones? Everybody always does the free parking. If you land on free parking, all the fees, all the fines everybody's been paying in, you stacked all of that up on free parking. Somebody hits that and lands on the jackpot and claims it. Yeah, that's not in the rules. What's another big one? The jail. In the official rules, when you're in jail, you can still collect rent. If somebody lands on one of your houses or one of your hotels, you're charging them. You're still making money. My family, we always did away with that. My family, if you were in jail, they wanted it to hurt. They wanted you to feel it. We got rid of that. What's another good one? Auctioning. In the rules for Monopoly, if you land on a property that nobody owns yet, either you buy it or it goes up for auction. Anybody can buy it. Nobody does that. My family never did that. There would be empty spaces all around the board. That's why Monopoly takes so long. Anyway, the fundamental thing here is you've got to be mindful of the rules. Something that I learned recently, there's a US and a world champion for Monopoly. The US champion, it's just some guy who lives in Buffalo, and he has competed and won the US Monopoly championship. The guy that's won the world championship, he's this guy named Niccolo Falcone. He's a random Italian guy that lives in Venice, and I got briefly obsessed with him because his name sounds like he's either a Batman villain or an extra in The Godfather. But what both of them have in common is they're both attorneys, like me. We like rules. If you talk to either of those guys, what they will tell you is that the reason they won, the reason they became champions of Monopoly, is that they learned the rules, they understood the rules, and they made the rules work for them. So that's kind of what we're going to dive into here. Some of the rules governing self-funded plans, some of the rules governing how they work, what they can do, what they can't do, and when they can do it. So a big one, the big overview, whose money is it? It's the employers mostly. There are contributions that will come in from the employees, kind of like premiums under a traditional insured plan, but all of that money is going into the plan. Risk, how's it spread around? Really, it's not. All of the risk stays with the employer. They do spread that around in limited ways by purchasing things like stop loss to cover catastrophic claims or high dollar claims that they come in. They might offset some of their fiduciary responsibilities through some of the programs like what the Phia group offers. But ultimately, all of that risk, all of that responsibility, all of that stays with the employer. Now, self-funded plans, they've grown a lot. They've grown significantly since the passage of the ACA. You can probably understand why when you look at the employer mandate. Basically, any employer with 50 or more employees has to offer coverage. And that means that more and more employees, more and more employers, regardless of their size, now have to find some way of funding benefits. And rather than going to fully insured plans and having to buy into that very rigid system, more and more of them have found ways to self-fund their coverage. So why self-funding? Premiums for fully insured plans are never going down. That arrow only goes up. There's limited exposure when you're self-funding to some of the other rules and medical loss ratio requirements. You don't have to deal with guaranteed issue rules. The stop loss premiums, that coverage the plans do purchase to kind of cover their back end for claims costs, for high dollar costs, that's not going to be as affected by the volatility in the market or some of the ACA rules. And really, it just makes plans, a little better, faster, stronger, lighter on their feet, better able to kind of roll with the punches of their medical care and their benefits. So our rule book. These are the big ones. We're going to go through them at kind of a high level. We may not be able to dive into them terribly deeply, not all of them at any rate. But these are the ones that these are the rules of the road. These are the ones that self-funded plans have to operate under. And these are the ones that, this is how the self-funding monopoly game is played. So the ACA, just very high level, the prohibition against pre-existing conditions, the creation of the essential health benefits. I'm gonna go through these quickly. You should all be able to find these slides and look at them after the fact if you want to. The big one here, like I kind of referenced earlier, was the employer mandate. Basically, employers have to, one, offer coverage. Two, that coverage has to be affordable and provide minimum value, or employers get hit with big tax penalties, and you get a lovely call from everyone's favorite people at the IRS. A lot of these other requirements, they're big ones, but really I think the biggie here is the employer mandate. And then the preventive care mandate, having to cover preventive care services as defined by the USPSTF on a first dollar basis and at 100% when received in network is the big one that, from a compliance perspective, we'll get into a little bit more later, is the bugaboo for small group plans. ERISA, now this really is in itself kind of the manual that self-funded plans have to operate by. ERISA basically created the written instrument requirement, the rule that requires that self-funded plans memorialize their benefits, their limitations, all their provisions really in a written document that they share and amend properly following all the required procedures. Beyond that though, how the plan is actually operating, they have a lot of flexibility, a lot more flexibility than the fully insured space in how they design that plan. A lot of people, I was on the phone with a client the other day and he joked about wanting to, I forget exactly what harebrained scheme he was coming up with, but he said, ERISA, every ridiculous idea since Adam. It means the employer can do whatever they want. And I was just like, that's creative. It's not quite right. You would have had fun in my family Monopoly games. So a big one here too to take away from ERISA's requirement is the fiduciary duties. The plan sponsor is a fiduciary of the plan. They have to operate in the best interests of the plan and plan participants, and they have a lot of rules governing how they operate, particularly with relation to the actual plan assets, the money that's going into the plan to pay claims, to fund the healthcare for their employees. And federal preemption, we'll kind of dive into that one here in a minute a little deeper, but that's everyone's favorite part of ERISA. That one basically says that state regulations on insurance don't apply to you when you're a self-funded plan. So preemption in a nutshell is exactly that. It means that you're exempt from state laws, from state insurance laws. It doesn't mean you're exempt from all state laws. A lot of employers like to run a little far afield with what ERISA actually lets them do. But it basically means that any kind of state benefits mandate, any state coverage mandate, make whole doctrine, prompt payment laws, any of that would apply to a traditional insured plan would not apply to ERISA. HIPAA. This one in emails drives me insane because people half the time will put two P's in HIPAA. There's only one P, and that P does not stand for privacy. For the love of God, is the Health Insurance Portability and Accountability Act. It is effectively a privacy law. It governs how plans have to work with protected health information, PHI. It governs what they can do with that information without having to get a waiver from an employee. And it also establishes, the business associate agreement requirements that everybody has to sign to exchange data. And it does also implicate a couple other design requirements for health plans with things like the non-discrimination rules. Effectively, under HIPAA, you can't discriminate on the basis of a health factor. And the source of injury rule essentially limits application of certain plan exclusions where the injury was the result of a medical condition or the result of being the victim of domestic violence, which is a caveat that I feel like I could write in my sleep at this point when I'm working on a plan. COBRA. A lot of people are vaguely familiar with this law. There's a lot of really important components to this law, and this gets a lot of the employers I work with, honestly, in hot water. Half of the consulting questions I feel like I deal with are trying to sort out COBRA issues. We're not going to get into it too deeply right now. The Mental Health Parity and Addiction Equity Act, the MHP-AEA. This one has seen a lot of ink spilled over it here recently, especially in the wake of the CAA, which introduced the official requirement to perform and document a comparative analysis of your non-quantifiable treatment limitations. This is probably the slide that has the most alphabet soup on it. I apologize. But anyway, we're not going to get into it too deeply right now, but if you have any questions or issues with the Mental Health Parity Act, NQTLs, the Consolidated Appropriations Act requirements, reach out to the Phia group. We are more than happy to help. So again, the benefits of self-funding, what are they? You get perks. You have lower premiums. The contributions that the employees are paying, the amount of money that the employer is putting into that plan, none of that is going to an insurance carrier who's got their own employees and their own lights to keep on. All of the money that is going into the plan stays in the plan and is being used to fund the healthcare for the employees. You have a lot more flexibility in how you design your plan. Like I mentioned, you don't have to deal with state benefits mandates or state insurance laws. You can really get creative with how your plan is organized, with the types of things it covers, the way it limits things. You also retain more access to your own data. I don't know if any of you have ever tried to pry claims data out of a fully insured carrier, but it typically doesn't go well, and they don't want to give it to you, and they don't want you to use it. And that's because if you have that data, you can analyze it, you can use it to identify patterns and trends in your healthcare spend, in your employee population, and you can use that to tailor the coverage, tailor the benefits that you're offering. Again, with the ERISA preemption, you only have one set of laws effectively that you have to deal with. Federal law. You don't have to worry about every different state's scheme for regulating and controlling insurance. You have lower admin costs, especially for employers that are very brave, granted, but that take on all the administration themselves, that are self-administered. Most employers have to lean pretty heavily on consultants like myself, on TPAs, on brokers to help them understand and manage their plan. But even with all of that, they have so much more flexibility and so much more room to maneuver with their plan that they wind up saving money in the long run. And again, you can introduce, I'll talk about some of the unique options here too, but there are lots of different cost controls and utilization measures that you just don't find in the fully insured space. What are the risks? Well, frankly, political scrutiny, the self-funded space has invited the wrath of especially a lot of state legislatures who don't like self-funding. They seem to think that self-funding is a scheme, especially if you're a self-funded plan that offsets some of that risk with a stop-loss policy in place to back it up. So a lot of plans will try to find creative ways to regulate self-funded plans without directly getting preempted by ERISA by putting all kinds of limitations around their stop-loss coverage, for instance. I think Connecticut, Florida, there's a few states right now that are trying to put limitations in place specifically around how large a plan, how many employees an employer has to have before they can write coverage. They're trying to force self-funded plans to cover all of the essential health benefits dictated under under the ACA, and limit the flexibility that plans have by basically forcing them to retain all of their risk by making it impossible for them to get stop-loss coverage. So any self-funded plan does enjoy preemption mostly, but there are rules like that coming through the states that you have to be mindful of still. So best practices, really, a big part of what makes self-funding so powerful is that the plan and its employees are still personally directly invested in how that plan does and how that plan performs. And that's where having good member education, having a good HR team, somebody that can really teach the employees how their benefits and their utilization of those benefits supports the plan, supports the rest of the employees, helps them understand that by going to an urgent care center instead of a super expensive ER center that's going to implicate all kinds of other expenses, they may be saving the plan money, saving themselves money in the long run. There are, of course, like I mentioned, a lot of rules that do pop up. You have to be mindful of those. Consultants like myself and the rest of the Phia group, that's what we're great at. We're always keeping our eye on these kinds of things. So if employers do have questions, if brokers, if TPAs have any kind of questions about compliance, there's a lot happening, especially right now, as those developments kind of roll out. We're the people that you want to talk to help make sure you're on the right track, to help you know you understand what's going on and what's changing and why. So fiduciary duties, especially in the self-funded space, are one of the things that I think kind of gets a bad rap. It's sort of a double-edged sword. The plan is retaining a lot of the responsibility of administering the plan. They have that obligation to operate in the best interest of the plan and the participants. And they have discretionary authority as a part of that fiduciary responsibility. It lets them have that freedom to design the plan how they want, to resolve disputes and ambiguities in the plan language, to really dictate how the plan works. It gives them a lot of power, but it does give them a lot of responsibility. It means that they are basically on the hook for how that plan operates, how that plan designs, how that plan performs and doesn't perform. So that can cut both ways. And it will inevitably lead to disputes between the plan, between hopefully not its broker or its TPA, but often between the plan and like stop loss, for instance. Like I mentioned earlier, COBRA can get very tricky very quickly. And if it's not administered perfectly, a lot of stop loss plans like to try to exclude all of the COBRA claims that the plan is now legally required to cover. And if you don't have people in your corner that understand how COBRA should operate, how the plan should operate under COBRA, that can leave the plan holding the bag for a lot of liability. Putting transparency to good use. Like we were saying earlier, the plan retains access to a lot of its claims data. The plan has things like the transparency rules that are being hopefully bolstered right now by the federal agencies in response to some executive orders that just came out. That transparency can give the plan a lot more tools, a lot more weapons in their arsenal to try to find the providers and the networks and the facilities that are, being competitive in their pricing and being actually open and honest in their pricing, that will work with them in a way that makes sense and is fair. This is just kind of a list of all the things that the plan has the flexibility to do, the types of design decisions that the plan sponsor gets to make while they're working on their plan. Things like leave of absence and continuation of coverage, that's one of those aspects where that actually is state law still being very relevant to how a self-funded plan is designed. State laws that dictate employment law that aren't insurance laws generally still apply to the employer. The employer is a distinct separate entity from the plan. Any leave requirements under state law, the employer still has to be very mindful of, still has to comply with. But to the extent that those are continuing coverage, that employer is going to need to make sure that it's clear in their plan how that's being done. Or again, they're going to experience a lot of liability. They have to compare their plan, their employee handbook, all the benefits they're offering, wherever they're offering them, against each other and against their stop loss coverage to make sure that their liability is as contained and as controlled as possible. You're effectively operating without a net to an extent as a self-funded plan, which means you have to be very good at walking the tightrope. And this is just some of the other rules under how you have to operate as a self-funded plan, the notice requirements you have to follow, the communication you have to provide, and getting in a little bit more of that like gap review that you have to do to make sure that you're covering all the gaps, all the holes in your coverage and your plan design and your stop loss coverage too. So the flexibility to implement different cost containment measures that self-funded plans have is what makes them partly so strong. DPC is a very big one. The Phia group has a few other programs like auditing your own hospital bills. We'll pay you a percentage of savings if you identify an error in your bill, and it really incentivizes people to find mistakes in their bills where they're either being double charged or charged for things for services they never received. The diapers and wipes program has been huge for the Phia group, where if participants have their pregnancy and their childbirth at a preferred hospital, they get basically $300 a month to cover diapers and wipes, and everybody loves this program. I think Adam actually got a write-up in the Boston Globe that he keeps framed in his office because of that program. But that's kind of just a sampling of all the options the plans have, but the key to all of those is that they have to be implemented in a way that comports with the rules, or you're going to wind up creating more headaches than you're solving when you get a call from like the IRS or the DOL for not being compliant. These are some of the big carve-outs that we see, things for like dialysis. That one you always have to be careful that you're not inadvertently triggering some rules under the Medicare Secondary Payer Act. Specialty drugs, especially now with GLP-1s. I think this slide I wrote a couple years ago, but it definitely predates GLP-1s, or I would have called them out specifically. Carve-outs for those are possible. Finding other ways to source those are possible, but that's, again, something that if you're considering, you always want to talk to people like the experts at the Phia group that can tell you the best way to do it. We want to know why you're trying to get creative, and we'll help you figure out how to actually do it in a way that won't put you in hot water. And again, these are just some of the big concerns going along with specialty drug carve-outs. There's a lot there. I'm not going to dive into it too deeply. Again, if you have any questions, please feel free to reach out to me or to the Phia group. We're happy to help. Drug importation, another big one. Not going to get into it too deeply. Basically, if you're an individual bringing in drugs for self-consumption, it's probably fine. If you're trying to bring in drugs at scale through some type of employer-sponsored program, that could get dicey. I don't know if there's anyone left at the FDA to enforce it, but it is technically illegal. So DPC arrangements, I feel like this one's probably going to cut close to the bone for a lot of people here today. The IRS basically considers this, you've got the definition there, you can see that basically any contractual arrangement where healthcare is being provided at a no-cost basis to employees, that can constitute a DPC practice, which is great. The Phia Group uses a DPC practice. Our CEO in multiple staff meetings has brought up examples of him just being able to text a picture of a rash his kid has to Dr. Tremblay and then getting a prescription sent to the pharmacy down the street. And it's fantastic. Everybody loves the DPC program. The problem with DPC is that it is generally incompatible with a high deductible health plan and a health savings account, which is frustrating because HDHPs and HSAs make up verging on 30% of the health plan space. The general rule under an HSA is that you have to be covered under an HDHP and no non-HDHP coverage. Anything that is not an HDHP that an employee is covered through would effectively be disqualifying other coverage. There are exemptions under the IRS rules for permitted insurance and permitted coverage. Those are very narrow. Anything that falls outside of that would be considered disqualifying other coverage. And I would point out too that the threshold for establishing a group health plan is very low. Well, a lot of the times you'll see employers and even DPC providers who want to implement this program because they see how powerful and useful and good it can be for their employees, but they think, oh, well, it's too much work to properly write it into the plan, to implement an amendment, to write it all up. We're going to just pay for it outside of the plan. And you see the intuitive appeal to that. Like the employer's just going to pay this outside of the plan, no muss, no fuss. Some employers might even just throw down the company Amex when they go into the DPC carrier and try to cover it outside of the plan. But the threshold, again, for creating a group health plan is so low that anytime the employer is paying for healthcare on behalf of its employees in any kind of formal arrangement, it will establish a group health plan. And again, there's limited exceptions for things like gym memberships and wellness and disease management programs. But if the program is covering anything beyond preventive care, it will basically be considered disqualifying other coverage. Which means and the DPC itself could easily become a group health plan, triggering application of that like 20 slides I just glanced over, that entire rule book now applies. And what effectively you might have created inadvertently is a non-compliant group health plan. It may not offer all the preventive care benefits mandated under the ACA. You may not have a plan document in place. You may not have outlined COBRA or the rules for claims and appeals. All of those requirements that have to be included in a group health plan might not be, which could easily get you in hot water with the IRS, the DOL. The feds might come knocking, basically. And this is IRS guidance has basically really harped on this, that they consider any kind of typical DPC arrangement where the DPC, hopefully a good one, is providing more than preventive care, would be disqualifying. So what's the other option? Maybe you offer it under the plan. You go through all the rules, jump through all the hoops to integrate it into the plan, and you're paying for it inside of the health plan. Well, again, you're still gonna run into the problem where if the DPC covers anything non-preventive before participants hit that deductible, it doesn't matter if the participants are paying a small nominal fee. If they're paying anything less than full value for that coverage that they're receiving before the deductible is hit, it's going to basically disqualify the plan. Another thing that we've seen the IRS try to say, and I don't personally agree with the IRS's conclusion here. I don't think anyone at the Phia Group would agree with this conclusion, but what the IRS has basically said is that a DPC arrangement will basically be considered a form of insurance. They see an employer paying a regular fee to cover a benefit that may or may not be accessed by employees, and they consider that insurance and therefore disqualifying. So from the IRS perspective, I kind of tried to give them the benefit of the doubt of why they think that's the case. Again, I don't necessarily agree with it. I'm just telling you, these are the rules, these are the walls that we have to play within. And if you lose that HSA qualified status, that can be huge for not just that employee, that can affect the entire plan. their entire tax situation. Basically, the HDHP is no longer qualified, which means that those employees can't utilize their HSA. They can't contribute to the HSA. If the employer contributes to the HSA, those are overpayments, and those can potentially open the employer themselves to additional taxes and penalties. So the stakes for messing up the HSA qualified status of your HDHP can be very, very significant. So lastly here, I will say there is some hope on the horizon. There are people working on Capitol Hill that are trying to address this situation, trying to adjust the way that DPC can work with HSAs. This is a piece of legislation that I think has been introduced and tabled and introduced over and again over the last few years. It seems to maybe be getting some traction. We'll have to see. We'll have to see if the government can stay open long enough to pass anything. But the takeaway I would say is that just be careful when you're implementing DPC and talk to the people that know the rules so that you can use those rules to your advantage and become the monopoly champion of the world. And with that, I'll let you all enjoy the rest of your conference.